Hello everyone, I am Dr. Amit Singh, MBBS MD in microbiology, working as professor in the Department of Microbiology. Today I am going to discuss about the differences between amoebic dysentery and bacillary dysentery. So let's start with the topic. It is a very important topic and several questions has been asked from this topic. So let's start. So to start with just a brief, what is dysentery? Dysentery is diarrhea with blood and mucus. And what is diarrhea? Passing of 3 or more stools per day and or passing a stool more frequently than normal is called as diarrhea as per WHO. So if blood and mucus is present in the diarrheal stool, it is dysentery. The causes of dysentery may be bacterial, may be parasitic, but there are no viral and fungal causes. So bacteria can cause diarrhea, dysentery. Parasite can cause dysentery, but viruses, fungus, these two cannot cause dysentery. They may cause diarrhea, but not dysentery. And one interesting thing which I can tell you is that dysentery is almost always infectious in origin, but diarrhea can be infectious and non-infectious. So now coming to the bacterial causes of dysentery. So the bacteria which can cause dysentery are, first one is Shigella species. If you remember, Shigella species has got 4 subgroups. So all the subgroups can cause dysentery. And just for a quick recap, the subgroups are subgroup A, Shigella dysentery, subgroup B, Shigella flexneri, subgroup C, Shigella bordai, and subgroup D, Shigella sonii. Then 2 diarrhegenic E. coli can also cause dysentery. One is enteroinvasive E. coli and enterohemorrhagic E. coli. Okay. Then there are certain other bacterial agent which can cause dysentery, includes, first one is Campylobacter jejuni. Second one is Salmonella intritidis, which is a non-typhoidal salmonella. Then a species of Vibrio apart from Vibrio cholera, that is Vibrio parahemolyticus and Clostridium difficile. All these agents except Shigella species and enteroinvasive E. coli primarily causes diarrhea, but in severe cases they may cause dysentery. And these 2 agents, Shigella species and EIEC, the dysentery caused by them is called as bacillary dysentery. So basically bacillary dysentery term is for Shigella species, but EIEC cause a disease similar to shigellosis. So that is why bacillary dysentery includes the dysentery caused by Shigella species and EIEC. Now coming to the parasitic causes of dysentery. So there are 4 parasitic causes of dysentery. One is amoebic dysentery, one is ciliary, one is bilharzial, and one is dysentery due to trichuria, which is an intestinal nematode. So this amoebic dysentery is mainly caused by Entamoeba histolytica. Ciliary dysentery is caused by Bainatidium coli. Bilharzial dysentery is caused by a trematode, Schistosoma japonicum and Schistosoma mansoni. And the last one is Stachyroi stachula. So these are the causative agents of dysentery. So just to remember in this slide, we should remember that dysentery cannot be caused by viruses and fungus, and there are only bacterial and parasitic causes of dysentery. And in bacterial and parasitic, mainly the two important causes of dysentery are bacillary dysentery and amoebic dysentery, and rest of the causes are not very frequent. Okay. So to understand the difference, just a quick recap of the pathogenesis of both of the dysentery, amoebic dysentery and bacillary dysentery. Just a quick recap. If you remember that the infective form of amoebic dysentery is the mature quadrinucleate cyst. Once the mature quadrinucleate cyst enter inside our body through contaminated water and food, it will reach the intestine, and in the large intestine, it will form the trophozoite, and the trophozoite then enter into the mucosal layer of the large intestine through the crypts of Leberkun. So these are the crypts through which the trophozoites enter inside the mucosal layer, and this entry is facilitated by its own movement and by a release of a lytic enzyme, that is histolysin. Once it enters inside, it will penetrate deep into the submucosal layer, that is this layer, but it cannot penetrate the muscular layer usually. So it will travel transversely to the side and multiply there, and leads to a formation of a typical ulcer, which is characteristically in a shape of a flask with a narrow opening through which the trophozoite entered and a broad base with a muscular bed. So the typical ulcer which is seen in amoebic dysentery is flask shaped ulcer. Okay. Now coming to the pathogenesis of bacillary dysentery. So bacillary dysentery is primarily caused by the invasion of the bacilli into the intestine, and secondarily by the toxin production. But the main pathogenesis behind the dysentery is the invasion of the large intestine by the bacilli. So where they invade? They invade the colonic and rectal cells, and they will penetrate the M cells present on the follicular associated epithelium or follicle associated epithelium, FAE, which covers the mucosal associated lymphoid tissue, that is Spear's patches. So they will penetrate the M cell and they will multiply there and spread to the adjacent cells and leads to a formation of a transverse superficial ulcer. Usually these ulcers are limited to the mucosal layer, the lamina propria, but may extend up to the submucosa, but usually it is limited to the mucosal layer, and they commonly causes proctitis and proctocolitis. Whereas the toxins produced by the Shigella species is known as Shiga toxin. This is basically an exotoxin, but it has got the property of both enterotoxin and cytotoxin. Okay, and this Shiga toxin basically inhibits protein synthesis, and it has got two subunits, subunit A and B. So the toxin produced by Bacillary dysentery or the Shigella species inhibits the protein synthesis, and it is an exotoxin which has got both the activity, introtoxic activity and cytotoxic activity. So this is the pathogenesis. So what difference we can see in the pathogenesis of amoebic dysentery and bacillary dysentery? One more thing I wanted to add into this amoebic dysentery to help you understand the pathogen in a much better way, that suppose if this is the intestine, large intestine cross section, longitudinal section. So if you see, the ulcer are like pinhead and they are multiple in number, but the intervening mucosa is normal in case of amoebic dysentery. Whereas in case of bacillary dysentery, if you can see a longitudinal section of intestine, they form a superficial transverse or longitudinal ulcer. So all the mucosa is eroded in case of bacillary dysentery, whereas in case of amoebic dysentery, the mucosa in between the ulcer is normal. Okay. So now coming to the difference very quick. So first, the differences on the clinical symptoms or clinical presentation of amoebic dysentery and bacillary dysentery. So the onset of amoebic dysentery, as you can see, is slow, whereas bacillary dysentery is acute. The very obvious reason for this is the multiplication time. Obviously, the bacteria multiplies much rapidly compared to the amoebs. Because of that only, the onset of the disease is slow or insidious in case of amoebic dysentery, and it is acute in case of bacillary dysentery because of a rapid multiplication of bacilli. Now the fever you see is absent in case of amoebic dysentery but is present in bacillary. Fever is present because of release of toxins by the bacteria, whereas amoeba do not release any kind of toxins. So this toxins leads to development of fever. And similarly, the toxicity is absent in amoebic dysentery and present in bacillary dysentery. The abdominal tenderness is localized in bacillary and generalized in bacillary dysentery. So if you remember the pathogenesis which I told you, the ulcer in amoebic dysentery are discrete and the intervening mucous membrane layers are normal. So because of that, the abdominal tenderness is usually localized to the site of ulcer formation. Whereas in case of bacillary dysentery, so to go into much in a more detail of bacillary dysentery, I'll tell you. Bacillary dysentery is basically a descending intestinal tract infection. What does it mean? When a bacilli enter inside the gastrointestinal tract, it will reach into the small intestine. They multiply there itself in the small intestine and leads to symptoms like abdominal cramp, pain, fever. But then within few days it passes from the small intestine and disappear and reaches the large intestine, and then again the pain starts, but now the pain will shift to the lower abdominal quadrant. So that's why the pain is more generalized in case of bacillary dysentery, whereas due to normal intervening membrane and the ulcer are very discrete and located to a certain region, the abdominal tenderness is localized. One more thing I wanted to add in this, what are the common sites of ulcer in case of amoebic dysentery and in bacillary dysentery? Amoebic dysentery, the common site is cecum, followed by sigmoid rectal junction. Whereas in case of bacillary dysentery, once it entered into the colonic mucosa, the commonest sites are in colon, it is sigmoid and rectum. So it causes proctocolitis and proctitis. Okay. Now the another presentation, tenesmus. Tenesmus is absent in amoebic dysentery, whereas it is present in bacillary dysentery. So why it is present in bacillary dysentery? If you remember in the pathogenesis, I told you the ulcer is longitudinal and transverse and superficial. So because of that, and also the location of the ulcer is near the rectum, so that leads to a feeling of defecation all the time. So because of that only, the tenesmus is present in bacillary dysentery and absent in amoebic dysentery, because there is no such kind of ulcer near the rectum, or there is no such kind of transverse or longitudinal ulcer as in case of bacillary dysentery. Now coming to the macroscopic feature of the stool or the feces. So the frequency of the stool, in amoebic dysentery it is 6 to 8 per day, whereas in bacillary dysentery it is over 10 per day. So why the number of bacillary stool is more in case of bacillary dysentery? The primary reason is that initially the disease, bacillary dysentery, doesn't start with dysentery, it starts with diarrhea, and this diarrhea is because of the toxin produced by the bacteria. So this diarrhea leads to development of this toxin leads to development of watery diarrhea. So that is why the number of stool is more frequent. And secondly, once the bacteria reaches the colon, it leads to development of ulcer near the rectum. So it leads to tenesmus, that is frequent urge to defecate. So because of that also, the number of stool per day is usually more compared to amoebic dysentery, because there is no tenesmus and also there is no toxin production. So to understand, the frequency is less in amoebic and more in bacillary because of the ulcer and because of the toxins produced by them. Now the order. It is offensive in case of bacillary and there is no order in, offensive in case of amoebic and no order in bacillary. So why offensive in amoebic dysentery? It is offensive or foul smelling in amoebic dysentery because in amoebic dysentery, as you remember, the shape of ulcer is flask shape. So the parasite digested the submucosal layer and it is filled with the necrotic debris of the intestinal layer. So because of this necrotic debris, because it will not come out very frequently into the bowel because of the narrow neck of the ulcer. If you remember the flask shape ulcer, the ulcer is like this and the trophozoite will digest or will feed into the submucosal layer and leads to the necrosis of the tissue. But this tissue will not release very frequently because of the narrow neck. So it will release slowly and then it will become necrose. So because of this necrotic material present in this ulcer, the stool is offensive in odor. Whereas in case of bacillary dysentery, the ulcer is very superficial. So whatever material is damaged or sloughed out by the bacteria will immediately release into the stool. So there is no odor of the stool. Okay. Now the color. The color of stool is dark red in amoebic, whereas in bacillary it is bright red. Again the same reason, because of the necrotic material and altered blood present in that material, the stool color becomes dark red. Whereas in case of bacillary dysentery, as the lesion is superficial, the fresh blood will add into the stool and the stool color will become bright red. Now the nature of the stool, microscopically we see, in amoebic dysentery there you can find some feces, and in this feces the blood and mucus is mixed. Blood and mucus is mixed. Whereas in bacillary dysentery, most of the time you will find blood and mucus with little or no feces. The first reason is the toxin which leads to the watery diarrhea, and second the tenesmus, which leads to development of urge of defecation, but without any stool present in the intestine. So most of the time only blood and mucus will come from the ulcer and no feces in case of bacillary dysentery. Now the consistency in amoebic dysentery, as the blood and mucus is mixed with the stool, so it will not adhere to the container in which it is carried, whereas there is no feces, a very small amount of feces is present in case of bacillary dysentery, so the mucus will adhere to the container. So the whole stool will adhere to the container in case of bacillary dysentery, whereas it will not adhere in case of amoebic dysentery. Now the microscopic difference between these two dysentery. So microscopically, if you will observe the stool sample, you can find that the cellular exudates are abundant in case of bacillary dysentery, whereas it is very scanty in case of amoebic dysentery. The reason behind this is that the bacillary dysentery is basically an inflammatory process, whereas amoebic dysentery is not an inflammatory process, it occurs slowly and gradually. So because of that, the inflammatory cells are not present in case of amoebic dysentery, whereas in bacillary dysentery, as it is an acute inflammatory reaction, so cellular exudates can be present in the microscopic examination of the stool. RBC. So again, if you remember, as I told you, the trophozoite feeds the intestinal epithelial cells, intestinal submucosal cells, epithelial cells, and it also feeds RBCs. If you remember, the trophozoite do erythrophagocytosis. So because of that, these two reasons, the RBC cell membrane got damaged. So they will clump together. Once the membrane of RBC is damaged, they will clump together and it become altered and the color will change into yellowish brown. Whereas in case of bacillary dysentery, the RBC, because the blood whatever coming out from the ulcer is not altered, it is a fresh blood, so RBC there is no damage, so it will remain either discrete or in a rouleau formation, and obviously the color is bright red because of non-alteration. Macrophages, again it is few because of a non-inflammatory reaction, and it is several, and some of the macrophages may be seen ingested with the red blood cell. Eosinophils in case of amoebic dysentery is present, whereas in bacillary it is absent. So why it is present in amoebic dysentery and absent bacillary dysentery? Eosinophils basically is seen to be increased in cases of helminthic infection and some of the protozoan infection like amebs, because it helps in a antibody dependent complement fixation reaction of these parasites. So just to remember, you remember that eosinophil count is usually increased in parasitic infection, mainly in helminthic infection and in some of the protozoal infection like amebs, whereas it is not increased in case of bacillary dysentery. So in stool microscopy you will not be able to find the eosinophils. Charcot Leiden crystals. Charcot Leiden crystals are present in amoebic and absent in bacillary. Why? Charcot Leiden crystal is nothing, it's just disintegrated eosinophils. So once the eosinophil concentration is increased, obviously it will disintegrate, and the disintegrated needle shaped crystalline structure, which is called as Charcot Leiden crystals, will be seen in a stool. So obviously Charcot Leiden crystal will be present in case of amoebic dysentery, whereas it is absent in case of bacillary dysentery because eosinophils are increased only in amoebic dysentery. And obviously the motile bacteria will be present as usual because amoebic dysentery will not affect the normal flora, whereas in case of Shigella dysentery or bacillary dysentery, the normal flora will got altered and most of the flora of the intestine will be the Shigella species, which is a non-motile species. So motile bacteria will be absent in bacillary dysentery. And obviously you can find amoeb only in case of amoebic dysentery, and there is no amoeb in case of bacillary dysentery. So now let's do a quick recap of the differences between these two. So clinically, onset is acute in case of bacillary dysentery because of rapid multiplication. Fever is present in bacillary dysentery because of inflammatory mediators, cytokines and toxins. Toxicity is present in case of bacillary dysentery because of the toxins and other mediators. Abdominal tenderness is generalized in case of bacillary dysentery because of descending intestinal tract infection nature of bacillary dysentery, whereas it is localized in case of amoebic dysentery. And tenesmus is present in case of bacillary dysentery because of longitudinal superficial ulcers. Macroscopic differences between these two in the stool examination. Number of stools per day is higher in case of bacillary dysentery because of the ulcer and because of the toxin produced by them. And the odor is offensive in case of amoebic dysentery because of the necrotic debris present in case of amoebic dysentery, whereas there is no necrotic debris present in case of bacillary dysentery. Because of that only the color is dark red, because of necrotic material and altered blood it is dark red, and it is bright red because of fresh blood passed in the stool in case of bacillary dysentery. Nature, the stool is mixed with blood and mucus in case of amoebic, whereas in case of bacillary, then primarily it is blood and mucus and very small or scanty feces because of toxins and because of tenesmus. Consistency adherent to the container because the mucus is only present, is not mixed with stool. So it is adherent to container in case of bacillary, and it is not adherent to container in case of amoebic because the mucus is mixed in the stool, so it will not stick to the container. Microscopically, cellular exudates are obviously more in case of bacillary because of inflammatory nature of the infection. RBC is either discrete or in bulle formation because it is not destroyed, it is not altered, the membranes are not damaged, whereas RBC is altered, membranes damaged, so it will clumped in case of amoebic dysentery. Macrophages is few in amoebic dysentery because it is non-inflammatory, whereas it is several in case of bacillary dysentery because it is inflammatory. Eosinophils, charcoal-ridden crystals and motile bacteria are present in amoebic dysentery. Because of its high percentage of eosinophils, charcoal-ridden crystals are present in amoebic dysentery because these are disintegrated eosinophils. And obviously, amoeba will be present in amoebic dysentery and bacillary will be present in. So I hope I was able to explain the differences between these two type of dysentery, and you don't need to memorize the differences anymore. If you have the concept, you can answer the question without even remembering the difference table. So all the best. I wish you best of luck for the examination. See you on the next video about the life cycle of Entamoeba histolytica. Thank you so much for listening.